Okay, and I'm going to share my screen. So it's a pleasure to present an overview of late effects of childhood cancer for you today. And thank you for inviting me to attend and participate in this wonderful conference. The objectives of the presentation are for you to appreciate the spectrum of long-term and late effects developing after childhood cancer, to recognize the impact of late effects on duration and quality of survival, to become familiar with strategies to mitigate late effects in survivors, and to understand the role for survivorship research on childhood cancer care and outcomes. So this international symposium has highlighted the tremendous progress achieved in developing curative therapy for children and adolescents with cancer. In high-income countries, 5-year survival rates continue to rise, with more than 80% expected to achieve 5-year survival. In the US alone, this translates to 1 in 750 individuals, currently an estimated 500,000 with a childhood cancer history. This is a globally growing population that has unique health risks related to their cancer experience that may have a significant impact on public health systems. Now, we know while overall survival has improved, survivors represented in the blue curve in this childhood cancer survivor study remain at risk for increased mortality compared to the general population represented in gold. This increase in late mortality is largely driven by chronic health conditions represented in gold, which increase in prevalence with increasing time from diagnosis and represent the leading cause of death in survivors by 30 years from cancer diagnosis. Now, several cohorts have studied the prevalence of chronic health conditions in aging childhood cancer survivors approximately 25 to 30 years from diagnosis. And on average, as illustrated in this table, approximately 2/3 of survivors have at least one self-reported condition, while 1/3 have a severe or life-threatening condition. And these numbers are higher in those for whom conditions are clinically assessed compared to self-report, as depicted in yellow for the prospectively assessed St. Jude Lifetime Cohort Study. Now, to clarify, the discussion today will largely focus on adverse effects that may present at diagnosis or during therapy and persist after completion of therapy, and late effects that have a delayed presentation, potentially many years after completion of therapy. But it should be noted that we have more limited understanding of how transient life-threatening toxicities during therapy, for example, tumor lysis or cardiopulmonary dysfunction associated with sepsis, may affect the long-term health of survivors. So hopefully future studies of clinically well-characterized and prospectively followed cohorts will be able to address this knowledge gap. Most often, survivorship research presents disease burden using cumulative incidence, as illustrated in this figure, which is limited to incidence of first event and may represent the tip of the iceberg of cancer-related morbidity. So you can see in the figure, which is using data from the St. Jude Lifetime Cohort Study that evaluated cardiovascular conditions in Hodgkin lymphoma survivors, the cumulative incidence of having at least one grade 1 through 5 cardiovascular condition in childhood Hodgkin lymphoma survivors noted in red compared to siblings in blue. You'll note that by 50 years of age, siblings appear to catch up to the level of morbidity. However, using the cumulative burden metric, which accounts for multiple and recurrent events in the context of competing risks, these two groups no longer converge. And you can see that survivors continue to have an excess of multimorbidity compared to their control cohorts. Now, the cumulative burden also provides a method that highlights multimorbidity across organ systems, as illustrated here, and each organ system has a different color code. The figure shows a proportion of organ-specific conditions in various diagnostic groups along the horizontal axis. And these are grouped by age, 30, 40, and 50. The cumulative burden of community controls across age groups is noted in the far left. And one can see that the burden of some conditions increase over time, such as cardiovascular health conditions in Hodgkin lymphoma survivors, while other conditions remain relatively static, such as neurologic conditions in CNS tumor survivors. So these patterns are useful and provide insight about conditions to prioritize in long-term follow-up of specific survivor groups and the latency to their appearance. Now, if you attended the talk earlier today about follow-up care, you've seen this figure, and it provides a useful framework to address the multifactorial contributions to the risk of late effects related to host factors, pre-morbid conditions at cancer diagnosis, genetic factors, tumor biology, specific treatment interventions, complications during treatment, aging, and health behaviors. So in the next several slides, I'd like to highlight examples of each of these contributing factors. First, let's start with tumor or cancer-related factors, specifically focusing on histology and site. So you can imagine in the above listed clinical scenarios, each have unique set of potential complications to consider in long-term follow-up. For example, as you'll see later in the talk, young women exposed to chest radiation as part of Hodgkin lymphoma therapy require ongoing breast cancer surveillance. Conversely, a retinoblastoma survivor treated with enucleation requires routine prosthetic fitting and adjustment, monitoring and potential education for support of low vision, and consideration of genetic risk and of subsequent cancers in retinoblastoma and offspring. An osteosarcoma survivor may also have prosthetic needs, or if they had contemporary therapy with limb-sparing surgery, require orthopedic support and follow-up, in addition to monitoring for other late effects related to intensive multimodality therapy, including cisplatin or high-dose anthracyclines. Now let's move on to host factors, and specifically here, I'd like to highlight age. Age at diagnosis influences the risk for specific toxicities. As an example, due in large part to the timing of brain development, younger patients are more vulnerable to neurocognitive impairment after central nervous system radiation compared to older patients, as illustrated in these figures from a study evaluating cognitive outcomes in survivors of childhood ALL. And these insults may result in decrements in full-scale IQ, academic performance, and memory, among other cognitive domains. Conversely, older females are at higher risk for ovarian insufficiency after low and moderate dose radiation, as illustrated in this figure from a St. Jude Lifetime Cohort study that evaluated acute ovarian failure among survivors according to age categories. And you can see that the older survivors in the 13 to 20-year groups have a higher prevalence of acute ovarian failure compared to those in the 0 to 12-year age groups. And this is due to the natural depletion of primordial follicles over the reproductive lifespan. In addition to host factors are treatment-related factors, which to date have appeared to be the largest driver and the most studied drivers of late toxicity. So we know that chemotherapy has unique toxicity profiles, as illustrated in this figure, and chemotherapy regimens administered vary by cancer histology, the tissues and organs involved by cancer, and cancer biology and response. So knowledge of the specific components of an individual's cancer treatment is critical to estimate their individual risk of late effects. And not only are specific agents associated with specific late toxicities, but these effects in many cases are dose dependent. And knowledge of cumulative doses for some agents is important in estimating the incidence and magnitude of risk of specific late effects. So the risk of heart failure related to anthracycline toxicity substantially increases at doses of 250 milligrams per meter squared or higher, as illustrated in the data and figures on this slide. And these are notable studies that show a threshold with exponential increase of potential for cardiomyopathy or congestive heart failure related to cardiomyopathy after reaching this threshold of 250 milligrams per meter squared or greater. As combined modality therapy is commonly used for pediatric cancer, the potential for additive toxicities should also be considered. So both anthracycline chemotherapy and chest-directed radiation have the potential for dose-dependent cardiotoxicity. And these figures demonstrate nicely the additive effect of these risk factors. So you can note that the cumulative incidence of heart failure, which is on the y-axis, and increasing age on the x-axis, both show the highest cumulative incidence of heart failure in those exposed to both modalities, chest radiation and anthracyclines, compared to those exposed to neither or either individual agent. As seen with chemotherapy, radiation dose significantly impacts risk of specific late effects. So in this figure, you see the risk of hypothyroidism after radiation. You'll notice that the y-axis reflects the proportion of study survivors not affected by hypothyroidism, while the x-axis represents years from diagnosis. Each individual curve represents survivors exposed to no radiation and categories of radiation, with risk being higher of being affected by hypothyroidism at higher doses. Now, conversely, the risk for a thyroid carcinoma, depicted in light blue, plateaus around 15 to 20 gray, with subsequently lower risk at higher doses, which is presumably related to reaching the threshold for cell killing. Higher doses of radiation are also known to increase risk for breast cancer in female childhood cancer survivors, as shown in this figure. Conversely, higher radiation doses to the ovary have been shown to mitigate risk for breast cancer seen in women exposed to breast radiation. This is likely due to the subsequent reduction in stimulating hormones produced by the radiated ovary. Now, aging and time from exposure are important to consider in assessment of risk of treatment-related late effects. So let's look at some examples here. If we look at two previously discussed associations, radiation and breast cancer on the left, and radiation and cognitive function on the right, you can see the relationships between age and time from exposure and the magnitude of risk. The development of breast cancer years after radiation exposure begins to occur around age 25, or approximately 8 years after exposure, which has largely informed the screening recommendations for survivors. Similarly, gradual worsening of executive functioning in ALL survivors exposed to 24 gray cranial radiation begins to occur as early as 12 to 15 years from exposure, compared to those who received no cranial radiation therapy. These associations have all led to the adaptation of a concept of accelerated aging in cancer survivors. All of our physiologic capacities decline over time with aging. This is inevitable. However, due to a series of known and likely unknown insults, cancer survivors appear to have an accelerated decline compared to the general population. And factors influencing the timing and rate of decline include heredity and genetic factors, lifestyle and health habits, exposures to toxins, access to health care and preventive measures, and of course, prior cancer treatment. So in support of this, I'll show you some data comparing outcomes among St. Jude Life and CCSS participants and those of the medical expenditure panel survey. And this figure compares the presence of any chronic health condition in the blue bars and 2 or more chronic health conditions in the yellow bars among survivors in St. Jude Life. Note their median age is 32 years. CCSS participant, their mean age is 27 years, compared to these medical expenditure panel participants who are 50 or years of age or older. And so you can see with the yellow bars, 2 or more conditions representing multimorbidity, that the level of multimorbidity in clinically assessed survivors is comparable and actually slightly higher than individuals in their 70s and 80s. Now, if we revisit the accelerated aging diagram, you can imagine where a series of interventions may be implemented that could potentially alter or mitigate the trajectory of this decline. And so these types of studies are a focus of recent research initiatives in pediatric cancer cohorts. So we have clinical evidence of accelerated aging that is supported by research that demonstrates specific cancer treatments do cause organ dysfunction at younger ages in our patients compared to the general population and can lead to diseases that typically develop at much older ages. The important factors to consider include that the results that we are now garnering from our cohorts as they're aging reflect outcomes of older treatment approaches that are no longer used. And many changes have been made in cancer treatments to reduce injury to normal organs and tissues. Now, moving on, let's look at pre-morbid conditions and health behaviors. Within the context of cardiomyopathy, the conceptual model illustrated on this slide seeks to organize an understanding of the influence of numerous risk factors. And so these concepts are applicable to other late effects, but they show here the potentiating as well as mitigating effects, that our survivors may experience in regards to a risk of a specific outcome. So you can see if you're looking at cardiomyopathy risk in relation to time from diagnosis, factors that may enhance that risk include anthracycline exposure, radiation exposure, the age at which you're exposed, and other cardiac comorbidities, as well as genetic factors. In mitigating risk, you have opportunities that help for healthy behaviors like exercise and healthy dietary intake, pharmacologic interventions, and aggressive management of cardiac comorbidities. So the influence of comorbid conditions and health behaviors on cancer-related effects have been studied by several groups. And so one study I'd like to highlight here that I think was a very important study showed quite elegantly the impact of an acquired chronic health condition, in this case hypertension, on the development of heart failure in survivors. And this is a childhood cancer survivor study that showed that hypertension, when combined with anthracycline, led to a multiplicative increase in risk that was almost 45-fold due to the interaction of the exposure and the condition. Now, on your right, you can see that increases in med equivalent hours per week of exercise were associated with a lower cumulative incidence of health-related mortality in survivors in the childhood cancer survivor study. And this finding shows great promise for exercise interventions to have a positive impact on health in our long-term survivors. Lastly, I want to briefly show you a few results from emerging data regarding genetic risks in survivors. On the top, you can see the risk of subsequent neoplasms in individuals with known predisposition mutations in blue compared to those without in gold. And so while no differences were seen based on radiation exposures, those with mutations were at higher risk for subsequent neoplasms associated with chemotherapy. On the bottom left, you see a dramatically increased risk for cardiomyopathy in individuals who have a homozygous GG genotype for the SELF4 gene, a SNP that is known to impact gene encoding for cardiac troponin T. And on the bottom right, you see how polygenic risk scores, or combinations of minor genetic variants when combined at higher frequencies, can contribute to the risk for breast cancer in childhood cancer survivors. So we have much more to learn about the impact of genetic factors in survivors. This is a rapidly emerging field that holds promise for precision survivorship care and actually precision care in directing frontline therapy as well. So what all of these risk factors culminate in is a medically complex population with diverse healthcare needs. This population is at risk for a number of adverse psychosocial and medical outcomes, as illustrated in the figure, and they're related to the complex interaction between all of these risks. And while sometimes we envision balancing the cost of cure as a dichotomous trade-off, it's often much more complicated. And this is why it's very important to involve shared decision-making in our discussions about treatment and our discussions about follow-up as pediatric oncologists with our patients and families. So it's important to note while the chances of late effects in survivors are high, the chance of serious late effects are actually low with contemporary therapy approaches, as I featured in my earlier talk. Given this, the mitigation of effects when possible should be first and foremost. And so this can be achieved through a number of prevention strategies. Let's see if I can get the figure. There you go. The first is primordial or intervention aiming to prevent disease through elimination of risk factors. And so here you might think of risk-adapted therapies that eliminate radiation from treatment regimens for favorably biological patients. Next is primary prevention, or an intervention implemented before evidence of disease or injury, but in this case, to mitigate risk, not necessarily eliminate it. And so the difference is subtle between primordial and primary. Then we get to secondary prevention strategies, which involve surveillance to facilitate early detection and intervention for those already at risk. And so this lends itself nicely to early tertiary prevention, which includes treatment to prevent progression or sequelae of disease once disease is present. So these findings have led not only to elimination of radiation for those whom it's unnecessary, but also modification to radiation fields over time. So in the figure above, you can see gradual reduction in tissue exposed to radiation depicted in green through the evolution of mantle to involved field to involved node radiation. And with this reduction in exposure to surrounding tissues, such as breast, heart, lung, and thyroid, you have a dramatically decreased potential risk for associated organ toxicities. Hodgkin's is also an excellent disease to look as an example of primary prevention related to cardiotoxicity. And so you can see in this table, there are 3 backbone therapies that are endorsed for high risk or advanced disease in the new NCCN guidelines and other pediatric cancer guidelines for Hodgkin lymphoma. Each regimen has shown to have similar efficacy. But when you look at individual drug exposures, you can see a wide range of cumulative doxorubicin doses spanning from 160 to 300 milligrams per meter squared, with or without radiation, depending upon the response and the regimen. And lastly, you can see the implications on cardiomyopathy risk and subsequent screening recommendations associated with each regimen. So while the choice often does not come down to a single organ toxicity, cardiac exposure and risk is certainly a key component in the shared decision-making of patients and providers as they're determining what is the best treatment options for an individual patient. Another way to prevent late effects is through secondary prevention, which is predominantly involved screening for asymptomatic disease. So several groups noted here have developed clinical practice guidelines for health surveillance of childhood cancer survivors. These clinical practice guidelines aim to standardize care throughout the lifespan that promotes healthy lifestyle, provides ongoing monitoring of health status, facilitates early detection of late effects, and provides timely intervention of late effects. Sorry, it's skipping. Results of observational research have also been translated into intervention studies that are focused on primary prevention of newly diagnosed children with cancer and secondary prevention among long-term survivors. So targets for survivorship research have focused on secondary and tertiary prevention, as noted on this slide. Most often, these efforts have aimed to increase survivors' health knowledge, their management of chronic symptoms, their practice of healthy behaviors, their adherence to follow-up and screening, early detection and prevention of disease, and self-management and advocacy. These interventions have less often, but certainly this is an area of emerging research, have focused on educating and activating and supporting healthcare providers in the delivery of high-quality survivorship care. And that's a struggle we're all facing, especially as we are interacting with very busy community primary care providers who are unfamiliar with childhood cancer and its unique health risks. So how are we doing with what we've learned and implementing our knowledge about cancer-related toxicities and the multifactorial nature of late effects risk? The good news is that the strategies to lower treatment exposures have led to reductions in overall mortality, as shown again nicely in a childhood cancer survivor study that looked at mortality from the 70s to the 80s and the 90s among cohort members. And concurrent with a reduction in mortality, CCSS also showed a similar pattern of reductions of morbidity over time in cancer survivors, depicted here as decreasing cumulative incidence of grades 3 through 5 chronic health conditions in their study participants. Pediatric cancer cohort studies have also learned to take data from their historically treated cohorts that probably are not receiving what we would consider as contemporary therapy, but looking at data according to treatment categorization that reflects contemporary therapy. And so these are several studies that are noted here, and they have demonstrated highly effective frontline treatment regimens that are associated with acceptable late effects profiles. However, systematic clinical assessment of ALL survivors in the St. Jude Lifetime cohort indicate that the spectrum, but not the magnitude of morbidity has changed, as illustrated here. And one again sees color-coded outcomes according to various system-based toxicities. And the horizontal axis shows the total therapies, the oldest to the most contemporary therapies, and the cumulative burden of specific conditions among survivors. And in this study, the investigators evaluated the burden of moderate, severe, and life-threatening chronic health conditions among these ALL survivors and observed that the spectrum, but not the magnitude of morbidity, has changed. In this case, there was a higher prevalence of musculoskeletal toxicity noted in blue, and endocrine toxicity, which was also high in the earlier total studies, largely related to hypothalamic pituitary dysfunction, actually remained high in the more contemporary studies, but the conditions contributing to endocrine toxicity related more to impaired glucose metabolism and overweight and obesity. Now, these factors are important for us to consider as childhood cancer survivors are at risk for related adverse events, as we've demonstrated. And we know that these events are multifactorial in etiology, but largely resultant from the curative cancer treatments. Temporal improvements in treatment and supportive care have reduced the morbidity and mortality experienced by survivors. Surveillance programs and ongoing research initiatives are imperative in order to continue to improve cure rates and optimize quality of life for all of our survivors. So I'd like to close with, in particular, thanking our survivors and families who over time have represented our most important research collaborators in our ability to improve outcomes. Thank you for your attention.